Hi, everybody. I am thrilled today to have a team from MIDI Health join us. Today's topic is Menopause Matters, supporting your body and well-being after gynecologic cancer treatment. The description is Dr. Goldman of MIDI Health will lead an informative and compassionate discussion on menopause, tailored specifically for women to women gynecologic cancer patients. This session will explore the physical changes associated with menopause with special attention to the unique experiences of those who have undergone cancer treatment. Dr. Goldman will share practical strategies for managing symptoms, improving quality of life, and navigating this transition with greater confidence and support. Participants will have the opportunity to learn in a welcoming space and gain tools to help them feel more informed, empowered, and connected. So, thank you so much for joining us. I'm going to say the floor. Thank you so much.
Okay, happy to be here. Okay, so just to remind people that this is a general educational talk and not intended to provide individual medical information. To tell you a little bit about MIDI, MIDI has a partnership with Mount Sinai. We are a virtual clinic for women in perimenopause and menopause. We provide care everywhere. We are in all 50 states. We are covered by insurance. We see almost 20,000 patients a week now. We have compassionate clinicians that are all educated in this area. And you can learn more about MIDI at joinmidi.com. Next slide. Just a little bit about who I am. I am MIDI's Chief Clinical Officer. I'm an OB/GYN by training, and my specialty is cancer survivorship. I've been on the faculty at UCSF in San Francisco for 30 years, where I still direct what's called the Gynecology Center for Cancer Survivors and At-Risk Women. I actually joined MIDI with the intent of scaling survivorship care and helping us launch a national survivorship program. I did that based on the fact that I have been lucky enough to do both this program at UCSF as well as a number of things nationally. I wrote the guidelines for the American College of OB/GYN, focused on the gynecologic care for women with breast cancer. I chaired the menopause and sexual functioning panels for the National Comprehensive Cancer Network. And I really wanted to scale this kind of care to reach women more broadly. Next slide. So some of the questions we get when it comes to cancer is, if you have a GYN cancer, does it affect when menopause will start? And can GYN cancer treatments and the different types of treatment cause early menopause? Does hormone therapy cause GYN cancers? Can I take hormone therapy if I have a GYN cancer? Can I take hormone therapy if I have a family history of a GYN cancer? And does the type of GYN cancer matter in terms of whether I can take hormone therapy? So we're going to go through some of these. Next slide. So before talking specifically about some of the GYN cancers, let's just go through a quick menopause overview. The definition of menopause is 1 year without a period. Average age in the US is 51, although there are differences depending on someone's background. Black women reach menopause on average about 8.5 months earlier than white women. When menses stop, it's important to realize that it's not that periods are going on completely nice, normal, regular, and boom, they just stop. There tends to be this transition period that is the reverse of what you see in puberty. So if you look at this chart, I think it really shows nicely that fluctuation in hormones that you see happening during what's called the perimenopause. So the perimenopause is the months or years preceding menopause, during which time people's cycles can change and they can experience all of the same symptoms that you see in menopause, but it is much more confusing because people are still having periods. And you can see on this chart up above that the length of time for the perimenopause is really variable. Although the average is 4 to 6 years, it can go on anywhere from 7 to 14 years. And that's where I think there's a lot of confusion for people because if you have someone who's in their mid 30s, they could be perimenopausal, and most people are not thinking about menopause if they're starting to have some unusual symptoms and they're in their 30s. Next slide. And just to realize when people start going through perimenopause, they can really feel symptoms everywhere. And that's because we have estrogen receptors throughout the body. We have it in nearly every organ and every system within the body. And estrogen withdrawal is real. Next slide. This just gives you a small sampling of the many symptoms that people experience during the perimenopause and menopause. Certainly, some of the more common ones are hot flashes and night sweats. Along with that is oftentimes trouble sleeping, either falling asleep or staying asleep, brain fog, memory lapses, mood changes, irritability. You do see higher risks of anxiety and depression at this time of life. Menopause does not cause it, but if someone is inherently susceptible to a mood disorder like depression or anxiety, this is a time period when you'll see it. Vaginal dryness, painful intercourse, difficulty achieving orgasm, low sex drive, weight gain, urinary urgency, stress incontinence, recurrent bladder infections. Many people don't realize that's a symptom of perimenopause and menopause. Hair and skin changes, and then some less common symptoms, things like itchy skin, dry mouth, uh, joint pain, irregular heartbeat, changes in bowel function, and really many more. I've read articles that there are 50 or more different signs and symptoms of menopause, and 85% of women have at least one of these symptoms. Next slide. Now, not everyone follows the same path to menopause. And if you have a GYN cancer, it can change that course. So, women with GYN cancers can have early menopause due to surgical menopause. Many times, as part of GYN cancer treatment, it will include surgical removal of the ovaries with immediate onset of surgical menopause. Many GYN cancer survivors have gotten chemotherapy, and many of the chemotherapy agents, particularly platinum-based, can cause damage to the ovaries and cause someone to go into earlier menopause. And then people who get radiation to the pelvis. We try to shield the ovaries many times, but when the ovaries are radiated, that can damage the follicles in the ovary, and that can lead to early menopause. So it's important to realize that depending on what type of GYN cancer and what type of treatment someone got, this path from perimenopause to menopause may vary greatly. Next slide. So again, specifically, we see surgical menopause when people have their ovaries out as part of their cancer treatment. Um, with chemotherapy, I mentioned the platinum drugs. Those are the ones that are more likely to cause ovarian toxicity. And in general, what we know is women who are over 40 who receive chemotherapy with platinum-like drugs are more likely to experience permanent menopause. If someone got chemotherapy and they were under 35, most often they will have return of some ovarian function. However, even for people who didn't need their ovaries out, got chemo, I know that would be uncommon in most GYN cancer situations. But even for someone who did retain their ovaries, it's important to realize that there's long-lasting damage to the ovaries such that people are predicted to have earlier menopause anyways. And then again, pelvic radiation can damage the ovarian follicles. And for some cancer survivors, the symptoms of menopause may be more severe because of the acute onset of menopause. Next slide. Um, Also, some cancer, GYN cancer patients may get different types of endocrine or hormonal therapies. So, in recurrent endometrial cancer, low-grade serous and endometrioid ovarian cancers, some granulosa cell tumors, and some low-grade endometrial stromal sarcomas. In some of those cancers, patients may be treated with either the selective estrogen receptor modulator tamoxifen or an aromatase inhibitor. Tamoxifen has lots and lots of gynecologic side effects, and one of the most common ones is temperature dysregulation and hot flashes and night sweats. Aromatase inhibitors shut down all peripheral production of estrogen in the body, and can cause severe symptoms like joint pain, vaginal dryness, and painful sex, more than menopause. So when women go through menopause, that means the ovaries stop producing estrogen, but all women have small amounts of estrogen made in other cells in our body, fat, muscle, brain, breast, all over the place by this enzyme called aromatase. When you give an aromatase inhibitor, you shut that reaction down. So you shut down all peripheral production of estrogen. And I'll explain to patients, you are more shut down than menopause. And so the tissues and organs that are really sensitive to estrogen are the ones that experience the most side effects. So bone loss, bones are really sensitive to estrogen. We see a higher risk of bone loss with aromatase inhibitors. Joint pain, our joints really like estrogen. And then the vagina, vulva, bladder is full of estrogen receptors, and people get just this horrific vaginal dryness to the point where sometimes they're sitting and the vagina can feel like sandpaper, like really significant problem. Next slide. What I want you to realize, there are many safe and effective treatment solutions. Oops, that was supposed to say GYN cancers. We didn't correct this. And at-risk women. So let's explore some of those. Um, the first is lifestyle and wellness therapies. And we know, at least we have the best data for hormone sensitive breast cancer, that regular interval cardio may decrease risk of recurrence and improve survival. We have less data with GYN cancers, but I put that in there because it is just as important for anyone with any type of GYN cancer to be doing the same amount of exercise. It's 150 minutes a week, divided times, interval cardio. It has so many benefits, both from cardiovascular health, decreasing cellular inflammation. And again, even though we have less data, it can be potentially important for recurrence. We're going to talk to people about diet and sleep hygiene. There's actually good randomized control trial evidence that something called CBTI, so it's a cognitive behavioral therapy focused specifically on insomnia, is a very, very effective treatment for people having sleep disruption. We may recommend CBT in general, or things like acupuncture. There are supplements and botanicals, things like black cohosh, ashwagandha, lavender. Certainly, we will take into consideration the context of someone's disease and whether things are, whether it's safe, depending on your specific type of cancer, the treatments you're on. But there are many, many lifestyle and wellness therapies that often can be very effective for treating some of these symptoms. For many people, I will tell them, identify your triggers. For example, for hot flashes, a lot of people will notice spicy foods, hot drinks, changes in ambient temperature, stress. Things can bring it on. And when people are able to identify what those triggers are, they're better able to control them. Next slide. Now, there are many non-hormonal therapies that can be used to treat symptoms. I think a lot of people don't realize that there are some that are FDA approved. We have FDA approved non-hormonal therapies that are very effective for treating the hot flashes and night sweats. One is called Brisdil, which is a low dose of Paxil. Paxil is an antidepressant that most people know of. Brisdil is a lower dose than exists for depression, found it effective, and they got it through the FDA as a non-hormonal treatment for hot flashes. Two new drugs, Veoza got FDA approval in 2023 and Linquit just at the end of 2025. They are really exciting drugs because they target the specific area within the hypothalamus of the brain where hot flashes are thought to occur. So they have helped us understand the exact mechanism of hot flashes. Very effective drugs. Linquit I really like because in the trials that led to its FDA approval, it also was found to improve sleep. Sometimes it's tougher to get through some of the insurance plans with some of these. Also, Veoza, there was a case of liver toxicity and it has a black box warning on it. And so people need to get their liver functions checked fairly frequently when they're using it. It is still a very effective drug, and the risk to the liver is incredibly, incredibly rare. The FDA was just being super, super conservative. And then we have a number of off-label use of huge number of drugs, many, many different antidepressants, neuropathic pain relievers, anticonvulsants, anticholinergics. Those are drugs used to treat symptoms like overactive bladder, urgency and frequency, and then even some blood pressure medicines. So I tell you this to say there are, even for people who aren't good candidates for hormones, there is absolutely no reason that someone needs to suffer because we have many, many treatment options. Next slide. And then we know menopause hormone therapy is the most effective treatment. I'm going to talk about the different GYN cancers, but when you look at effectiveness, no one will ever argue that hormone therapy is the most effective treatment. Hormone therapy consists of either estrogen alone, which is typically given when someone has had a hysterectomy, or estrogen with some form of a progesterone if someone has a uterus. Immediate symptom relief, 75% reduction in hot flashes and night sweats, 75% improvement in vaginal dryness and painful sex. Some people, I'm going to talk about vaginal estrogen because some people need vaginal estrogen on top of this, improvement in sleep and mood. And then there is evolving evidence of long-term benefits from hormones. So if people start hormones close to the time of menopause, lowers cardiovascular risk, and in the general population, that is the #1 cause of death. Some studies showing decreased death from all causes. It improves bone health, protecting against osteoporosis. And there's increasing evidence that there is this timing hypothesis window that it may be protective also for brain health. And I know that hormone therapy isn't right for many cancer survivors, but it may be appropriate for some. Next slide. Anytime that we talk about using hormones, it should be personalized. So again, it is best started under age 60 or within 10 years of the last menstrual period, and it comes in many different ways. Estrogen comes as an oral pill. There's an oral estrogen and a progestogen pill. There's an oral estrogen and what's called bioidentical progesterone. I'm going to talk about this estrogen and this SERM. And then there's transdermals. I would say we use transdermal formulations of hormones now more often because they bypass first metabolism through the liver, and that means it affects clotting profiles differently. So when you use a patch, a spray, or a gel, that does not increase the risk of blood clots, whereas oral estrogens, there are very small risk of possible blood clots. So many, many different ways that hormones come. Next slide. This one is really unique. So Duovi is a really interesting drug. And what it is it has an oral estrogen in it. And instead of using a type of a progesterone to protect the uterine lining from uterine cancer, it combines it with a cousin drug of tamoxifen. And we already talked about tamoxifen uh, is used as a treatment for some GYN cancers. I think most people have know of it because it's FDA approved for prevention of breast cancer, and it's very commonly used in breast cancer treatment. Tamoxifen actually in this class of drugs, SERM, selective estrogen receptor modulators, and each SERM acts differently in different tissues. Tamoxifen actually increases the risk of uterine cancer, whereas the SERM that is in this Duovy prevents uterine cancer. It's an FDA-approved type of hormone therapy for treating hot flashes and preventing bone loss. And there is some interesting data because of it has a cousin drug to tamoxifen. There's a lot of interest whether it may be a preventative drug for breast cancer. And there's some early data where it's been looked at in people at high risk for breast cancer, suggesting it may be preventative. There's no specific data in GYN cancers yet. I suspect this is something, though, that will be looked at because a lot of GYN cancer patients get thrown into menopause. And because some cancer survivors are treated with some of these hormonal drugs, I suspect we will start seeing some studies done looking at GYN cancer patients in Duovy. Next slide. And then there's vaginal estrogen. So when I talked about oral and patches, that is for treating what we call the systemic side effects, things like hot flashes, mood changes, sleep difficulties. Even though that will sometimes treat vaginal symptoms, for some people, it's not enough. And some people need vaginal estrogen on top of that. What's nice about vaginal estrogen is you're targeting the tissue of concern. You don't have to worry, if you have a uterus, you don't have to worry about progesterone because the doses of hormones stay locally in the vagina and are not absorbed into the bloodstream. It comes in different forms, a suppository, a ring, and cream form. And for those with GYN cancers where using systemic hormones is not recommended, most often we will recommend a suppository and ring formulation. As studies show, those formulations have been studied in cancer survivors and have not been associated with any rises in blood levels of hormones. With the creams, when you put a bunch of cream in the vagina, the surface area of the vagina is greater, and there's sort of theoretical concerns that it could be absorbed. So there are some types of cancers where we may say, be cautious with putting a lot of cream in the vagina, although people can always use creams rubbed onto the opening and the outside vulva safely. But virtually all cancer survivors can use some form of vaginal estrogen. Next slide. So now let's talk about menopausal hormones and different types of gynecologic cancer. Next slide. What types of GYN cancers can menopausal hormone therapy safely be used? So if someone has cervical cancer, any vaginal cancer, or vulvar cancer, none of these are considered hormonal, and people can safely use menopausal hormone therapy. So everything I've talked about, those survivors can use hormone therapy unless they have other health reasons where it wouldn't be recommended. Next slide. Let's talk about green lights, yellow lights, red lights. Green light, the most common cancers, endometrial cancers, are these early stage endometrioid histology. These are commonly present with bleeding. They are effectively treated with hysterectomy alone. We have no data that shows the use of estrogen impacts survival from early stage endometrial cancer. So people that have stage 1 or stage 2, the typical endometrial adenocarcinomas can safely use hormone therapy. Where is it a little bit more controversial? Serous endometrial cancers, Those are less likely to be hormonally driven, but more aggressive tumors. And there really isn't much safety data looking at the use of menopausal hormone therapy. Same with clear cell endometrial cancer or undifferentiated uterine cancers. The ones where it is clearly recommended to avoid systemic hormones. Again, this is not vaginal estrogen, but systemic hormones. People that have advanced endometrial cancer, stage 3 or stage 4, or even the early cancers with the endometrioid histology, if they have a high grade type. There is insufficient safety data. So generally, we recommend that people with those types of cancers avoid hormone therapy. And then mixed Mullerian tumors, it's generally recommended to avoid hormone therapy. Next slide. Uterine sarcomas, certainly a less common cancer subtype, but the low-grade ones are typically hormonally sensitive, and those are one of the cancers that may be treated with drugs like tamoxifen or aromatase inhibitors. So because of that, you tend to avoid hormone therapy for those cancers. The ones where we don't have much data, so I said more of a yellow light, is these high-grade endometrial stromal sarcomas. It's a rare tumor. It typically lacks hormone receptors, but there really isn't much safety data. So we'll individualize, but generally recommended to avoid. And then the ones with insufficient data, under-differentiated uterine sarcomas, a uterine leiomyosarcoma, and an adenosarcoma. Next slide. What about ovarian cancer? So the ovarian cancers that hormone therapy is okay. The most common type of ovarian cancer are these high-grade serous tumors. And there is no data that hormone therapy cannot be used in that situation. Mucinous ovarian cancers and malignant germ cell tumors, either a dysgerminoma, immature teratoma, yolk sac tumors. Those are all non-hormonal. Those are all green lights where systemic hormone therapy can be used. Ones that are more yellow light, serous borderline tumors. I would say typically at MIDI, we will offer hormone therapy to people that have a borderline tumor. An article just came out a month ago from this Italian consensus group that suggested maybe people should be a little bit more cautious in offering hormones to people with borderline serous tumors, that they may behave more like low-grade serous tumors that are hormonally sensitive. Again, this was just recent. I put that as a yellow light. I can tell you, typically we have offered those groups of patients hormone therapy. There's limited data in endometrioid ovarian cancers, ovarian carcinosarcomas, and Sertoli Leydig cell tumors. The ones where the types of ovarian cancer where you want to avoid hormones. Low-grade serous tumors. These are often hormonally sensitive, and that's another situation where sometimes the oncologist will end up using these anti-hormonal therapies. And so we typically don't recommend the use of menopausal hormone therapy. Endometrioid ovarian cancers that are low grade, grade 1, they also may be treated with some therapies like tamoxifen or aromatase inhibitors. And then granulosa cell tumors frequently express hormones. So typically systemic hormones should be avoided. Next slide. A lot of questions about family history and what about BRCA gene mutations, Lynch syndrome. These are really green lights. So for BRCA1 and BRCA2 carriers who undergo risk-reducing oophorectomy, this is in general healthy BRCA carriers who don't have cancer, hormone therapy is recommended at least up until the natural age of menopause. BRCA carriers are at risk not just for ovarian cancer, but breast cancer, and many of those patients may choose to have their breasts removed. If they have their breast removed, they can use hormone therapy without concern. Lynch syndrome. Lynch syndrome patients who undergo risk-reducing hysterectomy and removal of the ovaries are also recommended to use estrogen for hormone therapy. Because they don't have a uterus, they're recommended to use estrogen alone. And for those who don't undergo risk-reducing hysterectomy, at least short-term use up until the natural age of menopause is not thought to increase risk. And then family history of uterine cancer, we will individualize, but hormone therapy can be offered. Next slide. Testosterone. We get a lot of questions about, can I use testosterone if I have had cancer? So the best evidence for testosterone in women is for improving low sex drive. Large consensus groups got together and showed good evidence for that. There is a lot of questions about and sort of increasing evidence about other things, particularly bone and muscle mass, um, brain fog, cognition, fatigue, overall well-being. Data is not that strong in many of those areas. At least for bones and muscles, we have more data in men than women. We sort of extrapolate some of that for women, but that is evolving at MIDI. If we have patients coming in saying, I want to use it for one of these indications, as long as they understand it's sort of an evolving area, we will give testosterone. The issue about testosterone is it is not FDA approved for women. And because of all of the doping scandals with steroids, and this is a steroidal hormone, it got put on a controlled substance list. So it's a little bit of a hassle. You have to have a DEA provider that can provide that for someone. But there is definitely uses for women. I would say with cancer survivors, in general, we have less safety data. The ones that I'm most concerned about are people on aromatase inhibitors because testosterone could sort of overwhelm that reaction. But we will individualize, and there certainly are some cancer survivors that we will offer testosterone to. Next slide. Devices that can help with vaginal pain and pain with sex. Vaginal dilators. So this allows stretching of the tissue in a non-sexual setting to figure out what hurts and what doesn't hurt. It is really helpful post-radiation. It is recommended when people undergo radiation. And we also oftentimes recommend it when people are on aromatase inhibitors because those drugs shut down all estrogen. People can really have pain and tightening in the vagina. Sometimes we'll recommend people use topical anesthetics like lidocaine with the dilators. O-nut rings. O-nut rings go on the base of the penis and limit the depth of penetration. So sometimes when GYN cancer survivors have had surgeries and they have scarring at the top of the vagina, that when the penis hits up against that vaginal cuff, that can hurt. Or if someone's had radiation to the area. These O-nut rings limit the depth of penetration and can work really well for deep pain. Also, if someone has a lot of scarring post a cancer surgery, sometimes they have deep pelvic pain, and O-nut rings can help with that. Vibrators. I remind people about vibrators to bring back pleasure. I have a whole handout on different things that people can use both for pain and for pleasure. And then many times we will refer to our pelvic PT colleagues to help with any associated pelvic floor dysfunction. Next slide. So I want to give you a couple cases of typical kind of patients we see at MIDI to show you that we are very holistic and broad in what we recommend. So this person is 53. She had a recent diagnosis of stage 1 endometrial cancer, and she underwent a total laparoscopic hysterectomy and bilateral removal of her tubes and ovary. Her primary care referred to us, and she's complaining of hot flashes, night sweats, anxiety, and she had sleep dysfunction that on questionnaire sounds possibly consistent of sleep apnea. We counseled her that there's no data that the use of estrogen will impact survival from endometrial cancer, and we recommended that the most successful treatment for her symptoms is going to be giving her estrogen. She doesn't have a uterus, so she only needs estrogen alone. We recommended a patch form because that's the safest form. It won't increase risk of blood clots. And we started her at not the lowest dose, but the second lowest dose so that we can work up if we need to and work down if we need to. We recommended magnesium glycinate that can be helpful for sleep. We gave her information on sleep hygiene, on mindfulness. We gave her the National Comprehensive Cancer Network recommendations for exercise and diet. And then we referred her for a sleep study. So it's not that we just will say, okay, we'll treat your hot flashes. We have a very broad approach to treat someone's overall symptoms. Next slide. This is a person who is 50 and had a recent high-grade serous ovarian cancer. She is BRCA negative. She had debulking and completed carboplatin and paclitaxel chemotherapy and is now on Avastin. She reports being really drug sensitive and also has a lot of skin sensitivities. And GYN onc referred her to us because she had a lot of symptoms: hot flashes, vaginal dryness, painful sex. She tells us that she's always had long-term vulvar pain and she's chronically feeling stress. So we talked to her again about the safety of hormones, but because she has these skin sensitivities, we recommended oral estrogen and not a transdermal patch. Because she has so much vaginal symptoms, we actually recommended, in addition to her oral estrogen, giving her vaginal estrogen, and we recommended it in the form of a suppository. We recommended a what's called cortisol manager, which may be helpful in helping manage her stress. It has in it ashwagandha and L-theanine. We talked about lidocaine prior to sex, so a little local anesthetic to help out with the pain that she's had for a long period of time. We recommended cognitive behavioral therapy to help her with her stress. We referred her to psycho-oncology and then pelvic floor PT. So again, very broad treatment plan. And then I think I may have one more, or is that it? One more. This is a healthy BRCA2 patient, no prior cancer, anticipating risk-reducing removal of her ovaries. Her breasts are intact, and she tells us she poorly tolerated oral contraceptives in the past, also referred by her primary, and she wants to discuss, is it safe? Can I use hormone therapy after I have surgical menopause? We told her yes. We recommended a patch. And given that she didn't tolerate oral contraceptives, we thought, let's have her use off-label use of what's called a Mirena IUD, which can be placed at the time of surgery, and that will provide uterine protection. And then she, without getting the progesterone absorbed into the bloodstream, so fewer side effects related to the hormones. So we individualized the type of hormone therapy that we recommended for her. We know that after menopause, people need calcium and vitamin D, so we talked to her about that. We talked to her about lifestyle, interval cardio, all the exercise recommendations I mentioned, 150 minutes a week, divided times. We talked to her about hydrating skin creams. We talked to her about sleep hygiene if needed. And then she still has breast tissue, and we gave her referrals for her mammogram and MRI, and then a referral to a breast and plastic surgeon to talk about the benefits of risk-reducing mastectomies. Next slide. So we have a whole program focused on cancer survivors. We will give you personalized care plans based on your own personal history, your family history, your cancer type, your current and past treatments you got for your cancer. Our treatments are aligned with all the large guiding organizations. We will offer supplements when it's safe, and herbal, botanicals, all of that where there is evidence, and lifestyle strategies, integrative therapies. You have ongoing support from clinicians that are specifically trained in cancer survivorship and menopause care, and we will help to give you a clear roadmap to optimize your health both now and for the future. Next slide. I think that may be it. And the biggest thing is our patients feel better, and we're really proud of that. So surveys have shown that more than 90% of our patients feel better within 60 days. And I really do think for people who've had cancer, you need to have specialized menopause care and people who understand. You can see from the talk today, just with all the different types of GYN cancer subtypes, considerations for hormones are really, really complex. We have a very extensive training program that we do for all of our clinicians. We will work with you to figure out what's the best option for you and your body. And we really want to give you this personalized treatment so that you can feel your best. Can I explain hydrating creams? Yeah. So a lot of patients, a lot of people, when they go through menopause, notice drying of the skin. And so we will recommend moisturizing creams, sometimes with certain vitamins, like some of the creams will have vitamin C, like some of the facial creams will have vitamin C, for example. There are topical body creams that sometimes have vitamin A in them, vitamin D, sometimes oils. But oils penetrate skin nicely and penetrate the skin and can really help out. So it depends on the situation, but we found that a lot of people will come in complaining of dryness during perimenopause and menopause.
It's okay. I'm going to stop the recording now, so maybe people might feel more comfortable asking questions.